Now I've been given 15 minutes and then about 5 minutes for discussion. Am I audible? You all can hear, yeah. So we are going to talk about non-unions of the proximal humerus fracture. So my talk, as Mangal had suggested, is going to be essentially only cases. So these are cases from my practice, what I have learned from these cases and how I suggest you should deal with them when you come across non-unions of the proximal humerus. As you can see here, this case, this was I think more than 12 years ago. What a disaster this is to manage, especially 10, 12 years ago when we didn't have reverse shoulder arthroplasty. So can any of you imagine if you take away reverse from your armamentarium, then what a job to do and how to deal with this patient. So let me give you, so it's a difficult problem, and let me give you a wide perspective of how big or small is this problem and how often you will come across it in your practice. So first of all, it is seen often in elderly, in women more than men, as they are often osteoporotic. They have associated problems with the cuff. They have comorbidities. They are often diabetic, many other problems. And if you look at the literature, because of the aging population of the human race, there is an expectation of a threefold rise in the next 30 years of non-union of proximal humerus fractures. So we are going to see it more and more. So what is the overall incidence? First of all, proximal humerus fracture constitutes about 7-8% of all the fractures that we treat. So it's not relatively such a small, it's a common problem we all face in our practice, 7-8% of all the fractures. And majority of these proximal humerus fractures today are treated conservatively, as we all know. You need surgery in about 20%. And the non-union rate is ranging from 1 to 23%. So if you take an average, about 15 to 20% will go into non-union of all the proximal humerus fractures that you treat, whether you treat conservatively or whether you treat operatively. And they present with, essentially, if I summarize, what is the complaint? It's a dysfunctional shoulder. It's a flail shoulder. There is pain and there is stiffness. So effectively, it's a disabled shoulder. My friend from Brazil, Sergio Chechia, has come up with a classification. I don't like it. I don't use it. It is only for the sake of completion. I will give you my classification that I use. Pascal Beaulieu from France, he has this classification. Again, I don't like it. I don't use it. This is only for the youngsters who may get a long question or a short question in their exam. Then they must mention Pascal Beaulieu's classification. So what is my understanding? I think the first and the foremost when I deal with non-union, the first thing I'm going to ask is the age of the patient, because that will have a huge bearing on the line of treatment that I choose. Then I want to know just three things. Is it a simple head non-union? Is it a tuberosity non-union? And lastly, is it a combination of head and tuberosity? So this classification is simple. It is practical for day-to-day use. Two things you want to know, the type of non-union, and if you think carefully, the proximal humerus consists of what? It's head and tuberosities. So take non-union of head, means the surgical neck non-union, or of the tuberosities, or a combination of all three. And the treatment for all these three patterns will be based on age, and age. And this non-unions you will see in your practice is when there is human intervention, when there is orthopedic surgeons intervention, which means these non-unions you will see more often when a surgeon has attempted a fixation or a hemi. If you leave it to nature, they don't end up so often in non-union. So now, having got a proper perspective, what are the treatment options you have when you face a non-union? First and foremost, which often we tend to overlook, is you can leave them alone, because you have to think whether any further intervention is going to really help the patient. Then of course we have osteosynthesis with bone grafting. I've given this in red, hemi or total arthroplasty. Be careful. You have to be highly experienced if you want to produce a result by doing a hemi or a total shoulder arthroplasty. I'll tell you why. I'll show you cases. And of course, now we have reverse shoulder arthroplasty. So you have 4 options. I don't think there are too many other options when you deal with a non-union. So let's take option 1 and let me give you some examples from my practice. So this is a very effective technique. We all know that Dr. Mukhi is here. He is a fan of fibular graft. My teacher, Dr. Chobal, Dr. Tanna is not here, but we have all done this often, and they do well. So here is a 4-time operated patient of a proximal. This is essentially just the head. It's a little lower than what I gave in my classification, but operated 4 times. He's only 56. The fracture is too low for any other form of arthroplasty. So naturally, what we did is a fibula intramedullary graft with plating. He did well. And the literature supports. The literature, published literature, is 90% success rate with fibula graft. It's really cold here, huh? I'm shivering. The first time I'm shivering while talking. हाँ ये बंद कर सकता है उधर है स्विच so somebody else has which means I have very little fat in my body. Somebody else has suggested an only fibular graft. This is a Chinese paper, again for the sake of completion for the exam going students. This also works well, and this fibular graft has been placed medially, but it is not intramedullary. So now let me go to the option 2 and give you some warning signs that what is the role of anatomic arthroplasty when you treat non-unions. Beware, that's the warning to you. It has a high complication rate and it can have poor results. So let me show you some examples. 62-year-old police commissioner, city of Mumbai, had this kind of fracture. It looks like a 3 or 4 part fracture dislocation. Somebody did a fixation. As you can see here, the fixation failed. Doesn't surprise me. He came to me. I did this hemi, and I thought I did a good job. I thought that I'm very experienced in doing arthroplasty of the shoulder. It looked good. The tuberosity seems well reduced. The head size seems appropriate. The length of the prosthesis is quite good. 5 months down the line, look what happens. I'm a little concerned. The tuberosity is shrinking. Then I wait for another 2 months, and the tuberosity is gone. So if you see this, the behavior of the tuberosity, this slide is the summary for you to take home, that how tuberosity is a very sensitive feminine structure of the shoulder joint, that the moment you touch it, you manhandle it, it tends to disappear. So now this is the police commissioner. I'm in deep trouble. He came to a shoulder expert. I did a hemi, a good hemi, and now it is a cuff deficient hemi. So the problem is further compounded. But this is the advantage of coming to a shoulder specialist. I had put a platform stem, and because I had put a platform stem, it was easy for me to revise into a reverse shoulder arthroplasty. It didn't take much time. I took hour and a half. I removed the head component and I switched it to a reverse. He's now 3 years post-op. He's doing well. He's got full movement. But the point to take home is that when you have a delayed presentation of a tuberosity malunion or a non-union, be very careful because the tuberosity is very unpredictable in its behavior. We are not able to explain why, but the tuberosity suddenly melts away. This patient had no infection, let me tell you that. It's just the nature of the tuberosity. So this is my interpretation. I have many such cases to show you. So greater tuberosity, even if it is malunited, and the patient has pain and stiffness and a dysfunctional shoulder, you think I'll do a tuberosity osteotomy and realign it. Be careful. It can behave in an unpredictable way, and you can have a poor result. So has the world also noticed this? Yes. Pascal Beaulieu, 2001, he has published, and according to him also, if anatomic arthroplasty is possible without greater tuberosity osteotomy, surgeon should accept the distorted anatomy and adapt the prosthesis to the existing anatomy, but don't try to mess around with the tuberosity. Example number 3, she's a female of 64. This looked like a probably 2-part surgical neck or slightly below. Somebody did a hemi. Once again, be careful. I can tell you this is not a well done hemi. The head is too large. It is a little proud. The tuberosity is bound to disappear. So here it is. Now look at this. A very long stem, cemented hemi, and the tuberosity is gone. It's not united. It's a non-union of the tuberosity. Now she has a flail shoulder. Had he left it just like that, it would have probably done even better. And now we have a huge problem because we have to remove this cemented long stem implant and then do a reverse. Example number 4, another similar fracture. This looks like a 3-part fracture of the proximal humerus. Again, somebody did a hemi, a very badly done hemi. The tuberosity disappeared, and then we again have to do a reverse in a 57-year-old. So see that the tuberosity is gone. One more example, male 57. See the same. Cemented, non-union of the greater tuberosity, again a cuff deficient flail shoulder. So hemi, do not underestimate. I'm not saying hemi is a useless operation. Hemi for 4-part fractures, I do it. I will continue to do it, but you need to understand a few things about the proximal humerus, which I will summarize in my next 2 slides. So example number 3, example number 4, example number 5, all of this tell you all. What does it tell you? That can hemi for proximal humerus fracture ever do well? Is it something which we should throw away in the dustbin? And why does this procedure fail? So let me give you one example from my practice. This is a 4-part, very badly comminuted fracture of the proximal humerus in a male who is 58. And this is the result of a hemi. So in contrast to example 3, 4, 5, look at this example 6. Full forward flexion, full external rotation. We'll ask this gentleman to turn around, and full internal rotation, almost full internal rotation. He likes to play cricket. And there he is. He does bowl with that hemi. So now, what do we understand? I'm showing you many examples done by people which they have failed. Tuberosity has not united. It's a flail, useless shoulder. Is this: if you know how to persuade the tuberosities to unite. If you look at this slide carefully, the greater tuberosity has united, the lesser tuberosity has united. If you know the surgical trick, it is purely technical. If you know how to do it, I'm talking about fresh fractures, 4-part proximal humerus fracture in the arthroplasty age group. I hope I'm quite clear in that. So that means somewhere between 55, 60, and 70. That segment. Because above 70, I will go ahead and straight do a reverse because the unpredictability is overcome. So in this, how do we get to persuade the tuberosities to heal? And if they heal, they do very well. So first of all, look at tuberosities as female structures. They are feminine. They are delicate, sensitive, and they disappear on manhandling. And therefore, it is a very apt description that the tuberosity is a feminine structure. All orthopedic surgeons, men, understand the feminine structure. Therefore, if you compare the tuberosity to a female, and these 3 adjectives will help you operate on tuberosities with a different perspective. So the secret, how to get a good result with a hemi for a 4-part fracture. Look at, you all are trauma surgeons, look at tuberosity reconstruction when you're doing a hemi as an augmented osteosynthesis. Don't look at it as an arthroplasty. because your perspective changes. Your hand, the movements, the actions you do while operating, you'll stop using towel clips and you'll stop using cockers to hold the tuberosity. Be gentle. I don't even touch the tuberosity. Just take the ethibond sutures in the tendon bone junction. Don't touch the tuberosities. So look at it as an augmented osteosynthesis, and make sure that you know how to replicate the anatomy. If you distort the anatomy, the tuberosity will go away, which means two things you have to take care of. The height of the prosthesis, you have to be accurate. So what is the Lakshman Rekha? How much error can you make in achieving the right height of the prosthesis? 14 millimeters. That means if you go beyond 14 millimeters, the prosthesis, you put it too proud, say 18 millimeters, you will have a bad result. If you put it in too much, so you shorten the humerus by more than 14 millimeters, you will have a problem. So you must measure the normal side. Ask your registrar that on the blackboard in the OT, measure the other side from the acromion to the lateral epicondyle, say 32 centimeters, and write it there. So when you put a trial prosthesis, you measure with the tape intraoperative on the operating side that you reconstituted 32, and put your cementing or a prosthesis, actual prosthesis, exactly to that. That's one. And the second secret is the version. If you make an error in version by more than 10 degrees, you will have a bad result. Now, it's first of all, it's good to be armed with this information. And it's the next job is how to execute that. So for the length, I have given you the trick. For the version is the real tricky part, and that's where experience counts. So you might have to call me whenever you have a Hemi. So now, so role of anatomic arthroplasty, if I summarize in proximal humerus fractures, fresh or non-union, number one, high complication rate. Be careful. That Hemi I did, the tuberosity disappeared in the police commissioner. It can have poor results. So anatomic replacement should be abandoned in the treatment of non-union of proximal humerus. Pascal Beaulieu says that. I don't agree with that. You can use it, but you got to be careful. You got to be careful. Now, the role of reverse. We are going to option number 3, and I'll show you a series of 4 or 5 cases to make my point. So number 1, it does relieve pain. Reverse is, it relieves pain. It's more predictable, unlike the anatomic replacement. But it has a high complication rate. Even in the hands of the pundits, the complication rate ranges somewhere around 25%. I'll give you the literature. What complications? They are quite scary. You can have a dislocated reverse. You can have an infected reverse. You can have a refracture of the shaft. You can have nerve injuries. Let me give you example 1. Where does reverse fit in? So this is a Bollywood star's grandfather. He's 90 years old, and he came with this fracture to me. And I initially did suggest, I promise you, that let's treat conservatively. I was a little nervous. He said, no, I can't live with this for 2 months like this in a sling. It's too painful. I can't sleep. So I did a fixation. And I hope Dr. Mukhi agrees that it's quite a reasonable fixation. You wouldn't tell your registrar, no, this is not good. Take it out and put another plate. I think it is quite good. I did grafting also, and he comes to me after 5 weeks. So now I'm in deep trouble. He comes to me after 5 weeks with this kind of an X-ray. So now I have a non-union or a potential non-union of the proximal humerus fracture. I don't think I could have done anything other than reverse shoulder arthroplasty. He is now more than 18 months or 2 years down the line, doing very well, has got good function, a shoulder function of almost 80%. He's happy. Another example, case number 8. This lady is only 56 years old. I have no hesitation in saying this patient is from Delhi. And this is the kind of fixation Delhi does. These are the kind of X-ray she comes to me with. That surgeon over there, whoever removed the fixation, tried to do a Hemi, got infected. The shaft is fractured. That yellow X-ray is all that the patient had. And now a 2009 case comes to me in 2012 with this X-ray. So think, ladies and gentlemen, when you treat proximal humerus fractures, this could have been easily left alone. Even conservative treatment would have done far better. So we are doing too much harm by not understanding the behavior of proximal humerus fractures. So this is a disaster. She's going to lose her limb. She comes to me, but now the infection is totally controlled. For the last 2 years, no infection, no clinical or laboratory signs, and I go ahead and do a long stem reverse shoulder arthroplasty. She's 3 years plus doing well, touch wood. Case number 9, a businessman. He meets with a road traffic accident, has a 4-part fracture dislocation, a bad comminuted fracture. Look at this hemi. Horrible hemi. I mean, there's nothing good about this hemi. This was done somewhere in Pune. Very proud. So he has broken the Lakshman Rekha. The prosthesis is beyond 14 millimeters proud. So can you guys anticipate what is going to happen to the tuberosity? He has crossed the Lakshman Rekha. So not to be surprised, the tuberosity is gone. And the very fact that this surgeon has had to do a coracoid osteotomy for the sake of exposure tells me that he is not experienced. In last 24 years, I have never ever had to do a coracoid osteotomy simply for exposure's sake. So the surgeon doesn't have enough experience. He is not aware of certain retractors and the surgical technique to expose well, and therefore I am not surprised that this a very leading businessman of the city of Pune comes to me with this kind of X-ray. Now, a huge problem. It's his dominant arm, it's right hand. He is only in his 60s. He goes to England. He has lost faith in doctors in India because he is a wealthy businessman. The Englishman does a reverse shoulder arthroplasty. Now he comes 2 years post reverse shoulder arthroplasty to me again. He had met me then, but he decided to get operated in England. He got it done. 2 years post reverse, he comes to me, doctor, I have severe pain. I can't use the arm. And now it is an infected reverse shoulder arthroplasty. So I'm just trying to highlight that the extent of problem you will face. Now this is a very tricky situation, and I am now going to do a re-revision of the reverse. He's in the pipeline, and we are going to schedule that soon. So let me tell you what is the world experience of reverse when you treat proximal humerus fractures or non-unions. This is a busy slide, so as soon as Dr. Mukhi finishes clicking, we will go next to the complication rate. So if you see, look at the complication rate. I don't want you to look anywhere else. You can take a shot, of course. Look at the last line. So if I read the last line, complication rate 36%, 41%, 27%, and these are people with huge numbers. They are doing 400 reverse, 600 reverse, 26% overall complication rate. I'm not trying to scare you. What I'm trying to make you aware that you must know reverse shoulder. If you are going to treat proximal humerus fracture today in 2017, you will have to know the technique of hemi or reverse both, number one. And number two, you will have to train yourself, because even in the hands of experts, the complication rate is 20 to 30%, which is too high. And the complication is such that you will have nightmares. And I will show you some. So when you do a reverse, which is the first complication you will come across? When I'm talking about reverse for proximal humerus fractures, non-union or otherwise, the most common complication is unstable reverse, dislocation of the reverse. Why? Because these are situations where there is proximal humerus bone loss. And in that, to achieve the right tension so as the reverse to be stable is the surgical skill, is the experience, and is the technique. So number one, try to preserve the tuberosities. Why? Not so much for function in a reverse. Reverse will handle that, but it is only to achieve stability of the reverse arthroplasty. Try to use a large glenosphere because it enhances stability. And if required, on table, if you feel that it's still unstable, then you can lengthen the humerus by up to 23 millimeters. If you go beyond that, there is a risk of nerve stretching. So these are the tricks how to avoid the most common complication of a reverse shoulder arthroplasty. But you have to know reverse because it may be the only salvage option. Think about that Delhi lady. What else can you do? There is no other alternative. So often it will be the only salvage procedure. It does relieve pain and improve function. And dislocation is the most common complication. So now let me show you many of these cases from my series, 1, 2, 3, 4, 5, 6, 7, and I can go on. And Dr. A.J. Thakur is a very good traumatologist sitting here. He will agree with me that whatever is the fixation technique available today in the world, there is a problem. It is not understanding. The technique available today has not understood the mechanics of the proximal humerus. They tend to fail too high. We have to think of something different. You may use a locking plate, you may use a golden plate, silver plate. There is a problem with the fixation technique. There is a fundamental flaw. And Therefore, innovation has to come in the fixation technique. This is just an example to make the young minds to think that we will have to think of something different, which addresses the valgus angulation that we need to achieve and maintain. So this is one of the technique. It's a French implant. It's an intramedullary implant. This lady did well. It is healed. Another example, right-handed male road traffic accident, proximal humerus fracture, only 46 with a brachial artery injury. We did a vascular graft, and we did this technique. He's 6 months post-op, it's healed. So take-home message, proximal humerus fracture nonunion. Number one, prevention is better. If you are in doubt, conserve. Don't touch it. Young patient, of course, osteosynthesis, intramedullary fibula or other bone grafts as the situation demands. Elderly, reverse. But take extra care to avoid an unstable reverse. That's the commonest complication. And remember, if you're wanting to do an anatomic hemiarthroplasty, the result can be unpredictable. Last case for you, for the coffee. This is India, and I love this X-ray. I call this the unascended testes. Non-union of the proximal humerus. Thank you very much. Thank you, Mangal.
Thank you, Sanjay. So we will open for questions now. Yes, Dr. Anta.
Sanjay, thank you for a lovely lecture, very inspiring. You have shown as an expert 2 cases, one of a celebrity and the celebrity's father.
He only treats celebrities.
No, I'm talking about he doing the fixation and at having, and the policeman. What was the problem that you did not anticipate, and what care you did not take that it failed? Please be honest and tell us.
First of all, I love Nicholas.
We love you, Nicholas.
I am ruthlessly honest. And I said in Vyrock 20 years ago, I love Nicholas in front of 600 people. And I continue to love him. So, the police commissioner. The police commissioner, it was a failed fixation. He's 63 or 64, I forget, but he's somewhere in his early 60s. Failed fixation, I could have gone and done a straight reverse. But to me, reverse bhi, lafada ho sakta hai. So reverse I use only as a last option, especially if he is 62, 63. If that police commissioner was 70, no 2 thoughts. I would have gone and done a reverse and got out safely. I did a hemi because he was 62. I don't know how long he's going to live. Now, I took all the care that I teach and I talked about when doing a hemi. So the answer to your question, why did that tuberosity disappear? Very simple answer. I don't know. I don't know. He asked me to be honest. I'm being honest. I don't know. And I don't think the world knows. Maybe it's the vascularity. Maybe this blood supply coming from the attached cuff is not adequate. Maybe the implant. The implant I used, one point, scientific point. The implant I used is a very, it has a thick proximal component, the implant. It doesn't have enough fenestrations for the bone graft to go in. And therefore, we are expecting the tuberosity to heal to the proximal shaft, which is a tough order. So maybe the implant needs to be improved upon in the days to come. There are implants. Tournier, which is one of the world's leading shoulder company, is not yet in Mumbai. I've been trying for last 6 years to get them here. So they have the proximal humerus hemiarthroplasty implant with a lot of holes in it, big holes, for the bone to grow in and put grafts in that. Maybe that could be the reason. But the answer is, I don't know. Now the Bollywood star's grandfather, it was a good fixation. My feeling is, though he denies, I think he had a fall. He's 90-year-old, he must have fallen. He has an attendant with him 24 hours. I asked the attendant, कि वो साहब गिरे हैं क्या? तो मालूम नहीं साहब, मगर वो ऐसा उठते हैं कभी रात को मेरे को बोलते नहीं हैं. So that could be the reason. You can't blame the fixation because I had done it.
Both your fixation did not have the calcar screw. Can you comment on that?
I had put a big corticocancellous bone graft, and there was a calcar screw. There was a calcar, and I also grafted it immediately.
But does the calcar screw protect your fixation?
No. So don't get sold out on the calcus screw.
screw, exactly.
It's good to have. It makes you feel a little more comfortable. But the fact is that it's not a God screw. Yeah.
You said that you should not handle the
GT.
tuberosities. We generally, whenever you do a deltopectoral incision, you generally, the tuberosity is posteriorly displaced. So you have to get it out by holding with a towel clip or something. So unless and until you do that, it does not come out from there with a deltopectoral incision. And in proximal humerus fractures, if you're fixing, probably the GT unites. But more often in the hemiarthroplasty, it disappears. So what is the reason for that?
I think yes, it is. I have done all these through deltopectoral. You just have to internally rotate the arm a little more for the GT to become nicely accessible. So it's. Yes, but you can do it gently. I'm sure you dealt with women. So as I said, it's a feminine structure. So do it. Be sensitive. Do it gently. That's one I can say. But one thing is possible. The way you take the ethibond sutures into the GT tendon area, I think we are strangulating the blood supply. So there is a trick in how to take those stay sutures, I call them stay sutures, in the tendon bone junction so that you can hold it and not squeeze the blood supply. How? We can talk depending on our relationship.
Sanjay,
I thought it's good to have some fun also. Yeah.
Sanjay, I have got a question. I must say I am biased against reverse shoulder surgery. I am biased against it. But coming from the so many series by experts who are doing 400, 500 and complication rate of 25%, should it not be given up, that surgery?
Oh no, it's a good point. I appreciate what you're saying, but understand that this is designed. See, the problem with the Western world is that once they have something, they go all out. Bistara potla sab bech ke bas reverse. We shouldn't do that. We are more matured and balanced than the Western world. We like the British, as you know, because you're trained in England. So reverse is here to stay. Full stop. Period. Reverse, you have to know. Why? Because there are situations where reverse ke alawa kuch nahi hai. I showed that Delhi lady. If you throw away reverse, what will you do? She is not ready. No, how will you leave her alone? There is proximal. No, but let me stop you. But no, wait. Let me first finish with his. Leave her alone. But I gave her result with the reverse. No, so reverse has to stay. So yes. So the first answer is reverse can't be thrown away. Reverse has to stay because it is a useful technology. It's a useful biomechanical concept. It does work. Now we have to fine tune it where you reduce the complication rate. So my job today is to first expose you all that what is the highest complication when you do reverse? Instability. In fractures I'm talking. And then I have given you tips how to overcome that. Sorry. You are.
In today's world, are we operating too much of proximal humerus fractures?
Absolutely.
With improper implants, probably. The plate is not the proper implant, probably.
And there, I can't blame you if you use a plate, because you have that's the trend in the world. But the world is not ready to accept the AO, the Swiss, the AJ Thakurs are not ready to accept that their implant is inadequate. Is inadequate. There is a problem with the implant. I'm not saying I have an answer. So what else? I'm working on it.
The medial side also needs support. The lateral side has got a medial side or an intramedullary.
So point is, my today's message is we have to think kuch aur banana hai and let it be make in India of Narendra Modi.
Sanjay, here.
You mean? Yeah, but because of trauma or because of surgery? Axillary nerve. So you are talking about what is the incidence of axillary nerve palsy in proximal humerus fractures, correct? I think it's small, maybe 2% or 3%, and majority recover. I have yet to come across a case के recover नहीं हुआ. एक ही है खाली वो धोलकिया साहब ने operate किया था, and see the Dholakia Saab's wisdom. I saw this patient 3 months back. 20 years back, this gentleman had a proximal humerus fracture, And this is the genius of KTT. Why? Because how difficult it is to judge axillary nerve palsy in an acute case. Very difficult. नहीं तो साहब ने पकड़ा था. I don't know how. So he said के वो patient मेरे को क्या बोला उन्होंने? दुल्हन साहब ने एक ही सवाल पूछा, शादी वादी हो गया, बच्चे हो गए, कुछ मत करो, छोड़ दो. बिकॉज शादी वादी है तो थोड़ा फंक्शन चाहिए, हाथ तगड़ा चाहिए, अब तो शादी हो गया. छोड़ दो. कंजर्व किया तो फ्रैक्चर यूनाइटेड. कंजर्वेटिव ट्रीटमेंट रियली वर्क्स. फ्रैक्चर यूनाइटेड, axillary nerve did not recover. Now he comes to me after 20 years because the cuff has started. Because cuff is undergoing, but the deltoid is still gone. So I cannot even offer him a reverse.
I want to ask one
Sanjay. Your two failed cases where you have done a fixation. Now both of them were in varus. The tuberosity was riding high above the articular surface. That is why they have failed. And your calcar screw, what you have used, was not in the calcar, it was in the center of the head. This, if it is in the center of it, the very fact that the head is not reduced anatomically, or it is in varus. So you have spoken a lot about replacement, hemi or reverse. For an age group of 40 to 60, there is no role of reconstruction or revision, refixation, where the tuberosities are fair, there is a good amount of bone in the humeral head.
Yeah, I am answering that question, Sandeep. I think you didn't hear properly. In young patient, osteosynthesis, osteosynthesis and osteosynthesis. That was my take-home message. Do I answer your? Yeah. I have not at all said that in a young patient do any kind of arthroplasty. This is the take-home message. Yeah.
Dr. Mukhi. Yes. No, you.
Okay. Putting a medial plate or the nails.
In the mic, please. We are recording
Putting
this.
the medial plate, right? Or putting in those nails in a closed way, creating a medial column, creating a intramedullary, the middle column, and then giving your support with your locking plate or no locking also at times. Locking plate is a panacea? No. If there is varus, you're bound to fail in a locking plate. And if I rightly say, the void which you have not filled, you have put in grafts in that patient on the inferior medial side. Had you put the fibula in that old man,
In a fresh case.
in that old man, that you're telling cell celebrity. I call them cell beauty.
Okay. Wonderful. So now, first point, very quickly in interest of time. I agree with you कि implant में कुछ revision चाहिए. Something new. Plate अकेला काम नहीं करता है. Granted. अब आप 20 केस करके मेरे को publish करो result. I will start thinking whether you want to do a intramedullary nail or this nail, rush nail, medial plate, 20 केस करके result दो, and I will start thinking. I am doing my own thinking for some other implant. But I get your point. I agree with you. A new implant has to be designed. I will wait for your paper. Number 2, that's you said about the celebrity. What did you say?
Cell beauty.
No, put in a fibula.
Now that fracture, if I had to do again tomorrow morning in a 90-year-old with a below surgical neck, thoda low tha if you realize that. I don't think in that kind of fracture I would do a fibula graft on day 1. I did bone graft it. I did bone graft, but I didn't put and I don't think I'm going to do another surgery on the leg to take a fibula for that situation. So,
Positional
Cancellous.
grafts.
Dr. Gadigone.
I did an allograft. I put a strut graft intramedullary.
Sir.
No, I put a strut intramedullary.
Sir, due respect to your surgical skill, literature said in elderly people 4-part fractures, the operative and non-operative treatments virtually they are same with the limited activities and limited shoulder movements. So
Yeah.
do you think that operating on an old age where 4-part osteoporotic fracture, it is a industry driven or it is a surgical driven?
This is my slide number.
Ayane, it's not come up.
ये स्लाइड क्यों नहीं आ रहा है? हाँ, ओके. गड़ेगोने साहब, ये आपका जवाब मेरा स्लाइड नंबर 4 में है.
लेकिन ऐसा होता नहीं.
Let me just answer your question. So I have already agreed, and the world agrees, that 80 to 90%, line number 2, of proximal humerus fractures do well with conservative treatment. So we are on the same page. काय भांजगड नाही आहे आपल्यामध्ये. मी अग्री करतो. Number 1. Now you may be saying that world is operating on 50% of proximal humerus fractures.
90%.
So we all know the world is corrupt.
So that says that probably one of the next BOS master series we should have on conservative treatment of fractures. For example, shaft humerus, which is 100% operated. That also 80-90% will heal without surgery. So.
I have a person who has worked with conservative treatment of the humerus, published papers with the cast treatment. And when he got the fracture, he was a registrar of Sarmiento. What he writes in his biography.
So,
Just read.
yeah.
Sarmiento, I was your registrar, and I was advocating conservative treatment for humerus. Let me finish. Let me give this fact. And when he got the fracture, he said, "It is miserable, sir. Please don't advocate to anybody."
This is stop. But Gadegone Sahib, I have to give one answer. Mukhi Sahib, one last answer. He quoted one paper from England, which was published 3 years ago, which shook the whole world. That कोई भी proximal humerus fracture को operate ही नहीं करना है.
The Profer trial.
Proper trial. It is a flawed trial. Error है वो trial में. In what error is where in the selection criteria.
Okay, last one.
Sanjay, you did uni, you showed uni in Tuque.
Uni means hemi.
No, the, you call it the uni, the French thing that you put inside.
Bobique, the intramedullary
Yeah.
device. It's
Yeah.
not 2, it's many, it's 20, yeah.
The two that you showed. Now, in a non-union, how do you decide, how do you decide that this thing will work regarding the vascularity of the head?
No, stop. So, first of all, let me share with you my experience. Once you have a non-union, by and large the head is vascular. You never have this combination where you have an AVN and a non-union. ऐसा होता नहीं है. अगर है तो केस रिपोर्ट बन जाएगा.
हिप में तो होता है.
हाँ?
हिप में तो होता है.
Sure. Hip किधर है मेरे को मालूम नहीं है. I'm shoulder. So non-union with AVN तो होता ही नहीं है. Number 1. Now this device I have not used for non-union. Forgive me. That was a fresh case, and my advice for that is only for fresh case to prevent a non-union. It is not recommended. I have not used it because I want to put a fibular graft inside. So if the implant is in, I won't be able to put a fibular graft.
No, we're closed. It just keeps on and on. Go on. Quick. Nail. Any experience with the intramedullary nail?
No. That is no future in that. Sorry. Unless it's a very low shaft. We are sticking to proximal humerus, and in that, मेरे इलाके की बात करो.
आएगा नहीं अभी ना?
So thank you once again. Thank you, Mangal. Thank you, BOS.
Sanjay.
Thank you.